Hi, everyone. My name is Matt Sterling. I'm a urologist in Bryn Mawr, and today we're going to talk all about male incontinence. We're going to talk about how it develops. We'll talk about the way we diagnose it, and we'll talk about different types of treatment options that patients have. And if you have any questions, please feel free to ask, and I'll answer them, the best that I can. So as I said, my name's Matt Sterling. I am a urologist in Bryn Mawr. Just briefly about myself, I grew up in Cherry Hill. I went to Penn State undergrad, so any Nittany Lions out there, season starts this weekend. Came back to Jersey for medical school. I did my urology residency at Penn, and then I did a fellowship in trauma and reconstructive urology, and have fellowship training and expertise in urinary incontinence, urethral stricture disease, men's health, as well as erectile dysfunction and Peyronie's disease, which is penile curvature. My office is in Bryn Mawr. So I always think it's really important to talk about how the systems work so that we can better understand what happens when it doesn't work and how we can fix it. So as you can see, urine is made in the kidneys and then flows down these small tubes called the ureter, all the way down to the bladder. The bladder is surrounded by a muscle layer called the detrucer muscle. And when patients are ready to urinate, that muscle contracts and urine is expelled out of this tube called the urethra. And there's another muscle that sits around the urethra called the external urinary sphincter muscle that prevents patients from leaking all the time. And all of these parts of the urinary system are really important in working properly so that patients can control their urination. And when a part of the system doesn't work, patients often have trouble. So we're all here tonight because this is a really common problem. So 50 million people in the United States suffer from overactive bladder, and nearly a third of patients will suffer from some sort of incontinence. And there's really two basic areas we're going to talk about tonight. So overactive bladder and incontinence. And incontinence comes in a few different forms, which I'll go into detail as the talk continues. Stress urinary incontinence, urge incontinence, and overflow incontinence. Each of them have similar symptoms. Each of them can impact the quality of patients' lives, but there's important differences in why they occur and how they're treated. And it's really important to have the correct diagnosis so we can figure out the right treatment for patients. So let's start with overactive bladder. So overactive bladder is the sudden uncontrolled need or urge to urinate. And it's really a name for a group of urinary symptoms. So patients with overactive bladder often have a very strong urgency where all of a sudden they have to go to the bathroom. They'll pee frequently, so more so than every 2 hours. They'll wake up at night frequently, so again, more than 2 times a night. Some patients will wake up every 30 minutes, every hour. Some patients will have leakage prior to getting to the bathroom. Now, the normal bladder, what it does is it holds urine at low pressures. And so what happens is it holds urine. Patients decide when they need to go to the bathroom when they feel pressure. They go to the bathroom, relax this muscle, the external sphincter muscle, and then the bladder contracts and you're able to urinate. In patients with an overactive bladder, what happens is the bladder contracts before you're ready to tell it to contract. And so it'll have a smaller capacity bladder, so you'll have to pee more frequently. And then those contractions lead to urgency. All of a sudden you feel like you're going before you are ready to go. So what is incontinence? Incontinence is the inability to control your bladder, which can present really in 3 different ways. So stress urinary incontinence is when the bladder leaks due to increases in abdominal pressure. So coughing, sneezing, laughing, lifting something heavy, more exercise, sexual intercourse, patients will leak. This happens in men after prostate cancer surgery or surgery for BPH, such as a TURP. Urgency incontinence, again, as I talked about with overactive bladder, is when patients get a strong, sudden urge to urinate, the bladder contracts when you don't want it to, and you leak before you can get to the bathroom. Overflow incontinence is leaking or dribbling urine because your bladder is too full. So this, again, can occur because you can't empty your bladder. And again, leads to decreases in quality of life and are all different problems that need to be correctly diagnosed so that when we fix it, we don't result in more issues. So when you urinate, again, the bladder contracts and pushes urine out of the urethra. Afterwards, the bladder will relax and fill again. anything that damages this mechanism can cause problems. And so when we think of what is the differential diagnosis in patients with incontinence or overactive bladder, we'll think of inflammation, we'll think potentially of bladder stones. Sometimes we'll have to think of bladder cancer, although that's not typically the first thing we think about when patients have these symptoms. Medical conditions such as diabetes can result in bladder control problems. BPH or an enlarged prostate, sometimes some spinal issues can cause it. Different medications can cause you to urinate more frequently or urgently. Alcohol use, caffeine use, spicy foods, artificial sweeteners, diet drinks, all of those things can impact the way that you urinate. Being overweight can put more pressure on the bladder, so that can certainly contribute to stress urinary incontinence. Some neurological disorders, so Parkinson's, multiple sclerosis, stroke, radiation therapy to the prostate or the bladder area can also result in bladder control issues. Surgeries in the pelvic region, so for men, the most common being prostate cancer surgery, certainly can contribute to stress urinary incontinence. And then urinary tract infections and recurrent infections can cause problems as well. So as many of you know, urologists will get a few different tests when you come to the office. So when patients come with new urinary complaints, I'll often start with a urinalysis, which will look for any blood in the urine, which will look for any urinary tract infections. The other things that we'll often do is a post-void residual volume. So that little ultrasound that we put over the lower abdomen will measure how much urine remains in the bladder after someone urinates. And that's really important, especially in patients with incontinence, to figure out exactly why they're leaking, okay? In patients that progress or have more severe symptoms, we will often get additional testing. So a stress test is a very simple test. I'll have patients cough or laugh or increase abdominal activity, and we'll be able to see if there's any leakage during those activities. Additionally, urodynamics, this is where we basically put a small catheter into the bladder, and we take measurements as the bladder is filling, and then take some measurements as patients urinate. And then we often will do a cystoscopy to get an anatomical view of the urethra, which is the tube that you pee through, the prostate, and the bladder to look for any potential abnormalities. Other testing that we'll get, so sometimes we'll get ultrasound of the bladder or the kidneys to look for any anatomical abnormalities. We may get a CAT scan, and then EMG or sensors that will measure the electrical activity of the muscles and the nerves in and near your bladder, again, to see if all the components are working together correctly. I will often have patients get a bladder diary, especially for overactive bladder and patients with incontinence. So it's really important for me to look at how much are patients drinking in a day. So sometimes patients will drink 5-6 liters of volume a day. Your bladder can only hold so much, so you're going to pee frequently. Patients will often drink a lot of caffeinated drinks or sugary drinks or artificial sweeteners, all of which can contribute to how much they're urinating. So understanding how much and what patients are drinking, understanding how many times they're going to the bathroom can be a good exercise both during the day and night. Some patients will think they're peeing more often than they are, or vice versa, and then the bladder diary really doesn't show that. So I find it's a very useful and easy tool that patients can do on their own. So when you're talking to your urologist about these symptoms, we'll then start to talk to you about treatment options based on what we think is going on. Excuse me. When we're looking at treatment options, we often start obviously with the least costly, least invasive treatment options first. And I'll go into detail about all of these. We'll go with lifestyle modifications first. We'll talk about oral medications. We'll then decide on what testing is needed. Again, the minimal amount of testing to get the diagnosis that we need, and then talk about potential procedures depending on what the issue is. And we all follow a fairly clear pathway. First, we start with the evaluation. We do conservative management, potentially medications. In patients that are not improving or continuing to progress, we'll reevaluate. Do we need to do a scope? Do we need to do urodynamics to look at the function of the bladder? Do we need to do other tests? And then based on these tests, we'll decide on more advanced treatments. And these are really the treatments for overactive bladder. And then I'll talk about the treatments for men with stress urinary incontinence as well. So some lifestyle modifications. I talk about this to all my patients with this issue. So the first thing is understanding your hydration. So again, how much are you drinking? Do we need to change the amount that you're drinking to decrease the frequency with which you're going? What are you drinking? So again, diet drinks with a lot of artificial sweeteners, sugary drinks, caffeinated drinks, energy drinks, really spicy foods. All of these things can irritate the bladder, increase frequency, increase bladder irritability. Exercise and weight loss can certainly contribute to improvements in stress urinary incontinence. So again, anything that's putting a lot of pressure on the bladder. So if you're holding more weight, you're going to put a lot more pressure on the bladder and increase your risk of leakage. I'll talk to patients potentially about biofeedback or bladder retraining exercises that they can learn. And then in patients with stress urinary incontinence, pelvic floor strengthening can be an important tool that patients use with a pelvic floor physical therapist to strengthen the muscles around the pelvic floor and decrease urinary leakage. In patients that have significant overactive bladder symptoms, or we've tried behavioral modifications and there's no success, we'll talk about some pills or oral medications that can work. How these medications work is they relax the muscle of the bladder, so that detrucer muscle that we talked about earlier, so that the bladder can hold more urine and can decrease urgency. So what it does is it decreases frequency. So if we're able to improve the capacity, you're going to have to urinate less. It decreases the irritability, so you'll notice decreased urgency. You'll decrease waking up at night. Typically, these medications are taken once a day. And I often tell people to try these for 4 to 6 weeks because they can take a little bit of time to work. There's 2 different classes of medications that have different side effect profiles. Some of them can have dry mouth, dry eyes, constipation. Some of them can result in blood pressure changes. So again, talking to your urologist, figuring out what's a good pathway. Sometimes we'll try one medication. Sometimes we'll try a second one before moving on to more advanced therapies. But you should typically try medications before moving forward. In patients that fail medications, we start to talk about procedures, and I'm going to talk about 3 procedures for overactive bladder or urgency incontinence. So the first one I'm going to talk about is sacral neuromodulation or sacral nerve stimulation. There's really 2 different aspects of this procedure that I want to talk about. So there's the test phase or the trial period. This is a minimally invasive procedure that can be done in the office, taking anywhere between 20 and 40 minutes. And it basically feels like acupuncture. It's a small needle that I'll put in the back, basically to find the nerve that controls the bladder. Okay. Once we find that nerve, we put a temporary wire in, and the wire stays in for a week. Now, this is a really great reversible way that we can test to see if this procedure is going to work for you. In patients that it doesn't work, no problem. We take the wire out. We haven't really lost anything or done any harm. In patients where it works, we put a small implant into the back. So basically a small battery under the skin in the back, so everything's internal. And what it does is it's a pacemaker for the bladder, similar to patients that have a heart arrhythmia and they have a pacemaker for the heart. It's the same thing for the bladder. Your bladder essentially has an arrhythmia, and this needs to control the nerves better. Studies show a decrease in frequency and urgency incontinence by 70 to 80%. Again, it calms the nerves that control the bladder. There's a cell phone, so if we need to change the device, we can use a cell phone to do so. It's MRI compatible, and the newest battery can last 15 years. So in my opinion, this is the best long-term solution or permanent solution for patients with overactive bladder or urgency incontinence. Posterior tibial nerve stimulation is another option. Similarly, it impacts the nerves that control the bladder. It's a little different in the sense that the nerve also comes down near the ankle. So this is a small needle placed in the above the ankle that can also decrease frequency and urgency. Patients come to the office, they get the needle stays in for 30 minutes. They come once a week for 12 weeks, and then they come monthly after that. I also view this almost like a long-term test phase. So in patients that have success with PTNS, in my practice, I'll often try to have them transition to InterStim, which again is a more long-term or permanent solution for them. Beyond the 12 weeks, personally, I think it's unreasonable to have them come monthly, but I do have some patients or some partners whose patients do that and have nice success. And it, again, done right in the office is a minimally invasive option that has good results. Botox is another option for patients with overactive bladder and urgency incontinence. So Botox is a medication that is injected into the bladder muscle, similar to patients that get Botox injections in other parts of their body, right? Into the muscle of their face to relax the muscles, to decrease wrinkles. It's the same thing in the bladder. It's injected into the muscle of the bladder. And what it does is it basically partially paralyzes the muscles of the bladder to decrease the irritability. So again, decreases the frequency, decreases urgency incontinence, with similar success rates to InterStim, meaning a 70 to 80% decrease in frequency and urgency. It's a really good option for patients, especially patients that want things done under local here in the office. Some of the negatives of Botox is it has to be repeated. So similar to patients getting injections elsewhere with Botox, it gets repeated every 6 months and has a slightly higher risk of urinary tract infection and a slightly higher risk of urinary retention afterwards. Again, it's important that you talk to your urologist and figure out which one of these 3 options is best for you in terms of what, risks and benefit profile you're willing to accept. I want to switch gears a little bit to male stress urinary incontinence, and I'm going to talk about 2 separate procedures. Before I do that, I'm going to talk about kind of the mechanism of what happens with stress urinary incontinence. So I'm going to use this model to guide our discussion. So men have a muscle that surrounds the urethra called the external urinary sphincter muscle. And in patients typically with prostate cancer surgery or patients that have had surgery for benign prostatic enlargement, what happens is that muscle that sits around the urethra and prevents patients from leaking can be weakened. And so if that muscle is weakened, patients will have leakage with cough, with laugh, with lifting things, with exercise. And this can be really debilitating for patients. And patients can ultimately develop really severe leakage and severe incontinence. In those patients, I'll typically talk about a few different options. So first thing I start with, as I talked about earlier for overactive bladder urgency, is pelvic floor physical therapy. So in patients with mild leakage, so usually I would say less than 2 pads a day, I often talk about pelvic floor physical therapy as a way to strengthen the pelvic floor muscles, to decrease some leakage, or at least provide some strength to give a higher success in patients with that ultimately move on to procedures for stress urinary incontinence. In patients that have mild to moderate leakage, so we're talking 3 pads a day or less of leakage, and again, this is typically after prostate cancer surgery or benign prostate procedures, what I do is I make a small incision under the scrotum in the perineal area and basically reposition the urethra with a small piece of mesh. And what that does is it provides a hammock of support to the urethra so that when patients cough, laugh, lift things, and the pelvic floor drops, this provides extra support to that area. It's a minimally invasive procedure, 1 small incision. Again, works really well for men with mild to moderate incontinence, and patients are back to their normal activities, honestly, most patients within 2 weeks. So it's a really awesome option for patients with mild to moderate leakage. Artificial urinary sphincter or inflatable artificial sphincter basically is for patients with all levels of urinary leakage related to stress incontinence. So this is a prosthetic device. There's 3 different components. There's a cuff that is around the urethra that mimics that external urinary sphincter muscle that I talked about before. There's a pump within the scrotum, and then there's a reservoir of fluid within the abdomen. And all these components work together. And so the cuff is closed at all times around the urethra. When patients feel like they have to urinate, patients will push the button within the scrotum. And what happens is that releases fluid from here. The cuff opens, and then patients are able to urinate, and then the cuff closes on its own. This has a very high success rate. More than 90 to 95% of patients are satisfied with the results from an artificial urinary sphincter. It can be used in patients of all levels of leakage, okay? And I will tell you, the happiest patients in my practice are patients that have had surgeries for incontinence. It really impacts patients' quality of life. And if we can fix that problem with one of the surgeries for overactive bladder or urgency incontinence, or we can fix that issue with a sling or an artificial urinary sphincter, those patients tend to be the most happy patients that I see. And it's super rewarding. The thing I would say is for these types of prosthetic surgeries, you want to make sure you're going to someone with reconstructive fellowship training. So someone that has extra training beyond their urology residency to do these types of surgeries, because they can be complicated and there's a lot of nuances associated with them. And that's an important factor when choosing where to go. So we have a few questions that I see there. If anyone else has additional questions, please feel free to add them to the chat, and I'm happy to sit here and answer questions for you guys. So the first question I see is, I don't have urgency, but lots of leakage. Does Botox help in this situation? And so it's hard to answer that, obviously, without knowing any significant history. So in patients with leakage, again, it can be a few different types. It can be urgency leakage. It can be stress leakage. And so if it's stress leakage, where there's leakage with increased cough or laugh or lifting things, then Botox doesn't typically help in that situation. If we find out that even if there's no urgency, but there's random leakage and it's due to an overactive bladder based on our testing, then yes, Botox will certainly help in that situation, even for men. Another question is, what does 2 to 3 pads mean? So when patients leak, they will often wear pads, depending on how much they leak. They might wear Depends, they might wear pull-ups. And so when I'm asking patients, how many do they go through a day? How many pads or little shields do they go through? Are they wet? Are they not wet? And that'll guide me to determine how much leakage they're actually having. I'll have some patients that change 3 to 4 pads a day, but will change when there's a drop of urine on it. That's different than a patient that goes through 4 sopping Depends a day. And so that's an important factor in determining what options I can offer patients for leakage and how severe their leakage is. I had another question about needing replacement after some time. I'm assuming that's talking about the artificial urinary sphincter, but I can kind of answer it for all the prosthetic procedures. So for InterStim, again, the battery lasts 15 years is the newer battery. So the revision rate is very low for that surgery. Again, that's for overactive bladder. Slings don't have to be replaced. And then the artificial urinary sphincter, again, there's mechanical components involved. So as you can see, there's a few different components involved with an artificial urinary sphincter. There potentially is the need for revision. I tell patients the risks of patients needing a revision is about 20% for this procedure, depending on how far we go out. And most of them last 7 years or more. Okay. Going through some more. Okay, I'm going to go back. Question was, where is the prostate in your diagram of the connections with the kidneys to the urethra? So we're going to go back to the diagram. So the prostate sits here. So basically between the bladder and the outside world is the prostate. So it sits right here. Hope that answered the question. If sling procedure does not yield good results, can an artificial sphincter procedure still be done? The answer is yes. I will say I never go into a surgery planning to do more surgery, but certainly, yeah, in patients that have a sling and then their symptoms progress and we don't fix the problem, we can certainly put an artificial sphincter in those situations, and that's no problem. I will say I am fairly selective in who I offer a sling to. So there's patients that I know have a good chance of having a good result. And I know there's patients that have a worse chance of doing well. And so I have, certainly told people that a sling is not a good option for them, even if I can do it and I know I can do a sphincter after, because, again, I don't want to plan to do multiple surgeries. So if the sling's not going to work, then I try to offer them a urinary sphincter. Patient giving an example. So I had prostate surgery and a bladder sling, still having problems, 1 or 2 pads a day. Not sure if that's actually a question or not, But clearly, I think you should see a urologist. If you're still leaking and the leaking is bothersome, that's something we can certainly fix. No problem. Patient stating they have a lazy bladder and retention and in self-cath. Again, not necessarily a question there. So if that's something you'd like addressed, I'm happy to see you for that. I also manage BPH and any other urination issues. Trying to find, people are just listing their medical conditions without a question. If you have a question, please just ask a question. Okay, is UroCuff a useful test? For patients with BPH and prostate obstruction, I think UroCuff is can be a useful adjunct test. Basically put a cuff around the urethra, and it helps measuring the pressures in the bladder in a less invasive way. I will tell you, in patients that leak, so again, urgency leakage, stress leakage, urodynamics is really a better study. So I will not obtain a UroCuff in really patients that leak. Only in patients with BPH will I typically use a UroCuff. Again, not specifically in incontinence. Patient asking about urgency and frequency. How do you determine what is the best procedure for the issue? So, I honestly take a very detailed approach. So, understanding patients' history is really important. So, deciding what symptoms they're having. And then I think a workup before doing any surgery is necessary. So, not everyone does that, but I think it's important to do a cystoscopy, to potentially do a prostate ultrasound, depending on the issue, and then considering urodynamic studies if I still think I need an answer to why someone has a problem. Based on all of those, I basically offer patients different options depending on what their the risks and benefits are, and I kind of let patients guide what they want to do. I don't think it's my job to force people into one thing or another. I really like to work with patients and figure out, what ultimately their goals are in coming up with the best procedure for them. And someone asked about our office address. We're at 919 Conestoga Road in Bryn Mawr, 19010. Someone's asking about post-void dribbling or leakage after urinating. This is often a sign of BPH or some sort of obstruction process going on where some urine is getting trapped in the prostatic urethra or in the regular urethra. And so typically a sign of BPH, obviously I can't know that for sure without doing a full evaluation, but that's what's typically is a sign of. Spironolactone and overactive bladder, it can cause urinary frequency because it can cause you to make more urine. It should not cause urinary urgency. Patient kind of discussing having few leakage incidents a few times a year, occurs randomly, usually when seated. Long-time bicyclist, and have had benign prostate surgery. Again, without having a urine test or understanding a post-void residual, it's hard to provide exactly medical advice for that situation. But I always kind of determine if it's a bother to them. So if patients saw me for that and most likely they would not be super bothered. As long as their urine looked fine, I probably would just tell them to observe for leaking, 3 times a year. Probably would not lean towards doing anything aggressive, obviously. Patient talking about both urinary and fecal incontinence. These can be connected, and patients with fecal incontinence, interstim or sacral neuromodulation is a really great procedure that can treat both. The symptoms between urinary control and bowel control can be connected for sure. This involves, again, we need to do a workup because there's a lot of neurological conditions that can result in fecal issues. And so it's something we certainly need to advise on a case-to-case basis. Next one, mild nighttime leakage and some urinary retention, taking Flomax, and the bedwetting is more. So this to me would be concerned of what we talked about for overflow incontinence. And so patients that leak, especially at night, that have urinary retention, what's happening is your bladder is just getting too full at night. The fact that things are worse with Flomax is a little bit confusing. Usually Flomax will improve things for patients. That is certainly something that requires an evaluation and likely treatment. You know, the patients with significant nighttime leakage tend to be pretty bothered. And so those are patients we certainly get in for some diagnostic testing for sure. Is the first step to speak with a regular urologist, or should I make an appointment with you or another incontinence specialist? That's really up to you. You know, for what I do with my reconstructive training, I do have a lot of urologists that will send me patients specifically for urinary incontinence, for urethral stricture disease, for penile curvature, for complex voiding dysfunction. You know, I trust a lot of the urologists in the area, so I kind of have to leave that up to you in terms of, you know, if you have a good relationship with your urologist. I'd always lean towards speaking with your local urologist and kind of seeing what they think. Obviously, if you don't have a good relationship, then we're always here to help. You know, and then the other thing about an incontinence specialist, there's not many of us in the area. And so it really depends on what your incontinence is. So stress urinary incontinence, there's not a ton of us that do this or have fellowship training to do it. Overactive bladder urgency incontinence, there's definitely more of us around. So patients with incontinence, you know, I think it's important to see someone, you know, with specific expertise in this area. Do you ever suggest just putting in an additional sling? Not typically. I would say if someone's had a sling and that's failed and they have, you know, recurrent symptoms, I will not typically recommend another sling. I typically go on to an artificial urinary sphincter. Now, obviously, you know, I would have to identify, every situation is different. So I don't think it's fair to say, you know, carte blanche, I'll only do, you know, one thing for everyone, but typically if they've failed a sling, I'll move forward with an artificial sphincter. Does urinary leakage mean cancer? It can. I would say it's pretty uncommon in my practice when a patient comes to me for new leakage that this represents some sort of bladder cancer. That is not the first thing I think about on patients with leakage. You know, that being said, if we try medications for patients and their urinary symptoms are not getting better, it's really important to evaluate the bladder to look for reasons, you know, bladder stones, bladder inflammation, obstruction from the prostate. You need to really look at why things are happening if patients have new symptoms. But I would tell you cancer would not be the first thing I would think about when patients see me for new leakage. Is the artificial urinary sphincter an old technology? The sphincter's been around for about 40 to 50 years. I don't know if someone would say that's old or not old. It is the gold standard. So in patients with stress urinary incontinence, the artificial urinary sphincter has the best results in terms of success rates. Now, again, a sling is a really good option for patients with mild to moderate leakage, but patients with prior radiation therapy, patients with moderate to severe leakage, an artificial sphincter is really your best option. And it's the best technology that we currently have. There's really nothing better in my view. What is a trabeculated bladder? So essentially what happens is over years of obstruction from the prostate, what happens is the bladder works hard to urinate and the muscle of the bladder gets thicker. That thickening of the muscle is called trabeculation. And so what happens is as guys progress with their enlarged prostate and bladder issues, they can get a thickened bladder. It can lead to an overactive bladder, can lead to trouble emptying their bladder or long-term bladder dysfunction. So when patients have significant trabeculation, that's often a sign of more end-stage issues. Can you share the bladder log file? You could just Google voiding diary or bladder diary. There's a lot of good options The InterStim device is by a company called Medtronic. So they probably have voiding diaries on the Medtronic website that you can easily get and bring that to your urologist, which can certainly be helpful. All right. How long after prostate removal surgery can I expect to have urgency issues? Urgency is not typically something I see after prostate cancer surgery. It tends to be stress leakage. Now, you can have a situation where stress leakage results in urinary urgency. And so I will tell patients typically within the first 3 months, we start to see significant improvement in urination, but it can take up to 3 months. What medications are available to relax the bladder? I mean, there's a lot of different medications available. They come into 2 categories. There's anticholinergics, and then there's beta agonists or beta 3 agonists. The beta 3 agonists are mirabegron and a newer medication called Gemtesa. The anticholinergics, there's like 10 different ones that are available. And so there's a lot of factors that come into what medications I choose. I often have samples of mirabegron and Gemtesa that I will provide to patients to try for 4 to 6 weeks. And then depending on costs and side effect profiles will determine what their next steps are. Some of these older medications, although there's higher side effects, are much, much, much cheaper than newer medications. And so it's really up to the patient to determine what they want to do. What drugs can help with stress incontinence? The answer is none, really. Stress incontinence is an anatomical problem. And so typically this requires a surgery to fix. Again, pelvic floor physical therapy can certainly help, but typically pills will not help with stress urinary incontinence. That has to be fixed typically surgically. Patient says, I wake up once a night and urinate 180 cc's. Is this considered an overactive bladder? I would say no, that's not considered an overactive bladder. I would consider that fairly normal depending on your age. Obviously, we ideally don't want to wake up at all to urinate, but one time a night I would say is not atypical, again, depending on age. Is it normal when aging, so over 70, to have to urinate several or more times during the night? So I would say it's common in the sense that I see that very commonly, that patients over a certain age certainly will wake up more at night to urinate. Is it normal? No, normal is not waking up at night to urinate, but that doesn't mean it's not common, and that doesn't mean it's not bothersome. So I tell patients, if you're bothered by the way that you urinate, then that's something we need to address. Should we not drink before bed or when thirsty during the night? I tell patients that wake up a lot at night to try some basic things. So one is stop fluids 2 hours before bedtime if medically safe. For your other medical conditions, I tell patients try to avoid drinking overnight, try to avoid caffeine after 3 or 4 o'clock in the afternoon, and try to not eat dinner within 2 to 3 hours of going to bed. And so we start with that and we see if patients have improvement. In patients that snore, I recommend they talk to their primary care physician about getting a sleep study. Sleep studies are performed by pulmonologists, and sleep studies are really important in diagnosing sleep apnea. So patients that snore a lot and wake up a lot at night, sleep apnea is a very common reason that is a fixable problem that as a urologist I don't fix. I help diagnose patients that might have that, and then they kind of can see someone else to help that get fixed. How do bladder stones impact the detrucer muscle? Bladder stones basically just irritate the muscle. So patients that have a lot of bladder stones, what they're going to do is they're kind of move around the bladder like that. They'll irritate the lining of the bladder, and I oftentimes see patients get urinary frequency, urinary urgency, burning, or even pain when they urinate. The problem is bladder stones typically form from obstruction from the prostate. So patients will often have issues already, weak stream, trouble starting their stream, trouble emptying their bladder, and then the bladder stones can exacerbate that issue, getting more frequency, urgency. Patients often get recurrent infections. when patients have bladder stones, I typically recommend treatment for those. Does foul urine mean anything? It could, it might not. Different things that we eat or drink can cause our urine to change different colors, can cause our urine to have a different smell. I would have to evaluate, look at the urine, see if there's anything concerning in the office before I say whether that's a problem or not. Any other questions? That's all I have at the moment. Question of how do you test for bladder stones? Bladder stones are typically diagnosed on imaging. So oftentimes patients might get a CAT scan, might have blood in the urine and get a CAT scan or a scope. So typically patients will have other symptoms and will get diagnostic imaging, either an ultrasound or a CAT scan to diagnose bladder stones and then determine if we need to treat them or not. Does an artificial urinary sphincter need to be replaced? The answer is only if you're having issues with it. So depending on your age, depending on how you're doing, at some point over the lifespan of the artificial sphincter, it potentially could have to be replaced. Tell patients the revision rate is about 20% by about 5 years. It's about 40% by about 10 to 15 years. And so it doesn't mean everyone needs to be replaced, but it means that there's some patients that do need replacement and revision of their artificial urinary sphincter. Sorry, just looking at some questions. Just going to go to the last site there. Why can drinking soft drinks affect the bladder? There's some chemicals in different drinks, especially diet drinks, that just can irritate the bladder for some patients. So patients will get frequency, they'll get urgency, and some irritability. And so certainly different drinks can impact those issues with the bladder. I'll answer one more here, and then I think we'll be done. Thank you, everyone. So does constipation put pressure on the bladder and cause urgency? So the bowels and the bladder are really close together. So patients that have constipation or a full rectum, certainly that can push against the prostate, push against the bladder, and those can cause some issues. So patients can have urinary retention. We see that often in patients that get constipation where they have urinary retention, but they can also get frequency and urgency. And so patients with these symptoms will often put on medications to improve their constipation, and just doing that can certainly improve their urinary symptoms. I want to thank everyone. Hopefully this was informative. There's a link to our website there. I believe everyone is going to get a link to this video if you want to watch again. I'm totally happy to help in any way that I can. Again, I have a really strong interest in helping patients with incontinence, both overactive bladder incontinence and stress incontinence. And so, yeah, happy to help. Thank you, everyone, for participating. Really appreciate it. Take care.